welcome to today's IAC webinar, Pelvic Venous Disorders, Gonadal Venous Insufficiency. My name is Laura Humphreys, and I am the Director of Accreditation for Vascular Interventional at IAC. And now I would like to introduce today's guest presenter, Mr. Michael Grant. Michael Grant has extensive experience in the field of vascular medicine and currently serves as the Ultrasound Program Director at United Vein and Vascular Centers. Before joining United Vein and Vascular Centers, he worked at Pacific Vascular as a sonographer and team lead. Mr. Grant has worked to improve the diagnostic quality of studies sonographers produce through education and quality improvement initiatives. With that said, I will now turn this webinar over to today's speaker, Michael Grant. Michael?
Thanks, Laura. Hello, everyone. My name is Michael Grant, as Laura said, and I'm currently the Ultrasound Program Director at United Vein and Vascular Centers, originally from Denver, Colorado, but currently residing in Tampa, Florida. Today, I'm going to be talking to you about pelvic venous disorders, but before we get started, I want to give a special thanks to IAC for allowing me to speak to all of you, and a special shout out to Sarah Skonsberg for sharing some of the ultrasound images you'll be seeing today. So today we're going to cover quite a bit, which includes risk factors, anatomy and landmarks, the art of abdominal ultrasound, protocol zones, diagnostic criteria, symptoms, pathophys, the SVP classification, when to intervene, when to look up, meaning when performing lower extremity venous insufficiency exams, when should I be concerned about a proximal obstruction, and finally, I'll leave you with a few considerations. So pelvic venous disorders, what was it and what is it today? Most of us know pelvic venous disorder simply as pelvic congestion. The problem with only talking about this disorder in terms of pelvic congestion is that it has a narrow scope. Definition of pelvic congestion is chronic pelvic pain lasting 3 to 6 months, and the focus is mainly on women. The nomenclature has recently been updated from pelvic venous disorder to pelvic venous disorders for a few different reasons. The scope is broader, and although more women are diagnosed with this disorder than men, we need to include both sexes. So we now know that multiple reservoirs can be involved, which leads to a broader spectrum of symptoms. So overall, pelvic venous disorders is a more accurate term to use. Some of the risk factors, these include multiparity. The higher number of pregnancies, the more strain on the abdominal, pelvic, and lower extremity venous systems. Like a lot of different disorders and diseases, family history is a risk factor. We have age, habitus, and generally for this, it's patients with a normal habitus who are taller and slender. Hormonal disorders, clotting disorders, and prolonged sitting or standing. So the art of the abdominal pelvic ultrasound. Abdomen is a very scary place for a lot of sonographers. There aren't many landmarks. We don't have some of the same crutches as when we're scanning other parts of the body, i.e. angle steer. And we're often dealing with a lot of bowel gas that obscures ultrasound penetration. So I want to leave you with a few tips and tricks to help you be successful. Scanning the abdomen and pelvis and being successful at it is truly an art. So patient prep is huge. Do not skip out on the patient prep. A full bladder, generally 16 to 20 ounces of water 1 hour prior to the patient's exam, is key. Not only are we using the bladder as a window for better visualization of the uterus and surrounding vasculature, but a full bladder also positions the uterus most optimally for us to get true sagittal and coronal views. If possible, scanning patients first thing in the morning, while NPO will sometimes limit the amount of bowel gas present in the patient's abdomen and pelvis. Some facilities are strict with this protocol and others are not. In my experience, as long as you can get enough diagnostic information for the physician to make a sound and accurate diagnosis, patients that are not NPO should be seen when they arrive for their appointment and not rescheduled just because they forgot and had a light breakfast. Aside from patient prep, technique for this exam is absolutely key. Once you're familiar with anatomy and normal flow direction within the vessels of the abdomen and pelvis, a few things will set you apart from others. Scanning a large volume of varying anatomy with normal findings will allow you to quickly recognize when something is not quite right. I mentioned this earlier, and this is very important. You create your Doppler angles in the abdomen by using the heel-toe method. Curved probes don't have angle steer for the color box or pulse wave Doppler. And finally, although there aren't many, we need to know our landmarks. If you are performing transvaginal ultrasound for this exam, the patient must empty their bladder, which allows the uterus to fall more forward or from a posterior to anterior position, optimizing for transvaginal approach. So I want to take a little bit more time about talking about creating angles. In my opinion, training many vascular sonographers, this is probably one of the most important techniques you can learn while scanning the abdomen. It's a huge part of setting yourself up for success, especially in the abdomen where visualization and ultimately color filling and characterizing waveforms can be challenging. So if you create optimal angles, you improve your color filling. Your velocity angles will be spot on, and your waveforms will be cleaner and more diagnostic. So let's take a look at these three ultrasound images on the right. The smaller one on the left is an AP diameter measurement. Anytime we're taking a diameter measurement, we want to be perpendicular to that vessel. So if the vessel is in sagittal, because you can also take this diameter measurement in transverse, but if we're in sagittal, we want that vessel coursing straight across the screen. If the vessel is diving, we may overcall our diameter measurements because that increases our chances of being oblique to that vessel, not perpendicular. However, when we're taking a pulse wave velocity, we want the opposite. Again, we don't have access to steer our box or our Doppler, so we have to do that with our hands. In the two images on the right, I'm measuring the velocity in the same segment, but the pulse wave in each image is on opposite sides of the screen. How is this done? So in the top right image, I actually slid the probe towards the heart and angled toward the heart to give me a proper velocity angle. For the bottom right image, I slid the probe toward the feet and angled the probe toward the feet. Two different angles, same vessel segment. Practice this, and I promise scanning the abdomen will become a lot easier. And when this is new to you, a lot of people struggle with it. And they tend to give up pretty quickly. And then they kind of repeat the same technique, which causes the same issues they've been having over and over and over, sometimes years. So I would say practice this, get good at it, and it's going to set yourself up for success. It's going to set you apart from other sonographers also scanning the abdomen. So I did mention there's not many soft tissue landmarks in the abdomen. The pancreas is one of these landmarks that we need to get acquainted with. It lives in the epigastric region, just inferior to the left lobe of the liver, but can be hard to visualize for those who aren't used to looking at it. The epigastric region is difficult in a lot of patients due to the amount of overlying bowel gas, but if you can visualize the pancreas, your vessels of interest lie just deep to it. So in the picture on the right, the pancreas is outlined in orange. The SMA is the first vessel highlighted in red just deep to the pancreas and is often one of the culprits of left renal vein compression. Next deepest, you have your left renal vein draining the left kidney and coursing from left to right between the SMA and the aorta, which eventually drains into the vena cava just deep to the head of the pancreas. And finally, the aorta lies deep to the proximal aspect of the left renal vein. If you have a severely gassy patient and cannot see the pancreas, try having that patient take a deep inspiration to see if that aids in visualization. Often you'll be able to visualize the pancreas and the left renal vein in deep inspiration. That kind of moves your organs, your bowel gas down away from the rib cage. And I find that often when people do not use that technique, if you're doing a follow-up exam because it was poor visualization, if you use that technique, you're going to increase your ability to see the vessels that you need to see. And if you can see the pancreas, more often than not, you can see the vessels beneath it. The second landmark you need to become familiar with is the psoas muscle. The psoas muscle lies just lateral to the belly button bilaterally. Your probe will be oriented in a sagittal plane to view this muscle in long, and in a coronal plane to view this muscle in transverse. The gonadal vein measured in the middle image lies on the anterior aspect of this muscle and isolating the muscle in either plane when looking for the gonadal vein is generally the easiest way to find the gonadal vein. I generally have more success in sagittal. Others argue that they have more success in transverse. Neither is wrong. So you may have, depending on the patient, you may have to use both planes or both approaches in order to see this vessel. So as far as iliac and gonadal vein anatomy, the two images shown here are what we expect to see in most patients. The left gonadal vein is a bit longer than the right and drains into the left renal vein, while the right gonadal vein drains directly into the IVC in most patients. Left-sided dominance of the gonadal vein and iliac vein disorders may be explained by anatomic consideration. The left gonadal vein is longer than the right, which makes it more difficult to drain in the upright position. The IBC, on the other hand, lies just to the right of the spine. At the bifurcation near the umbilicus, the right common iliac vein dives straight into the pelvis, while the left common iliac vein has to course laterally, anteriorly to the spine in a transverse to oblique plane prior to diving deep into the pelvis once it reaches the left lateral margin of the spine. So this anatomical difference is likely the reason left iliac vein compression, formerly known as May Thurner's, is far more common than the right iliac vein compression. So this slide shows some not so rare anatomical variants in relation to where the left renal vein and left gonadal veins anastomose that you may come across while scanning. In the top left, the left renal vein is coursing posterior to the aorta. I like to point this one out because it threw me for a loop the first time that I saw it. I spent way too much time trying to find the left renal vein in its typical location between the SMA and the aorta, while the flow in the peripheral left renal vein was readily visible and normal. So I was scratching my head. I'm like, this vein should be readily visible. And I cannot find it until I remembered, light bulb went off in my head. I had learned about this some years ago. And then I looked posterior to the aorta and there was my left renal vein. So in the top right image, the left renal vein is connecting to the distal IVC just central to the IVC bifurcation. Bottom left image highlights what's known as a circumaortic left renal vein, where the left renal vein essentially has two trunks. One trunk is coursing in a normal orientation between the SMA and the aorta, while the other trunk is coursing posterior to the aorta. The bottom right image shows the left renal vein connecting directly into the common iliac vein, an anatomical variant that I have personally never seen. So I've seen 3 out of the 4. So today, we're not going to go through the full protocol. So instead of going step by step through that protocol, I want you guys to ask yourself, what questions are we trying to answer with a pelvic venous exam? So with a holistic approach in which a pelvic venous disorder workup includes the abdomen, pelvis, and lower extremities, ultimately we're directly and indirectly assessing for venous reservoirs. These reservoirs are the renal hilum, pelvic venous plexus, and the pelvic origin extrapelvic plexus, along with the lower extremities. During our indirect and direct assessment, we characterize lesions as thrombotic or non-thrombotic. And although most of us who perform these exams don't directly use the following language, we're also characterizing flow patterns as compensated or non-compensated. So we'll touch on this again a bit later in the presentation, and you'll see why this is highly important to your physicians who may be deciding whether or not to treat these patients. So now we're going to jump into some diagnostic criteria regarding the different veins that we are assessing during this exam. So in this image, we're looking at a left renal vein. In the ultrasound images on the slide from the left to the right, we're measuring the central, mid, and peripheral segments of the left renal vein. So again, left to right, we're measuring just distal to where that SMA is likely compressing the segment of the left renal vein that courses between the aorta. Or, sorry, just distal. I'll use proper terms. Just central to where that left renal vein is coursing between the SMA and the aorta. In the mid picture, we're looking at where compression is likely to occur. And then on the image on the right, we're looking just peripheral to where that vein courses between the SMA and the aorta. And for the left renal vein, we're looking at a velocity or diameter ratio greater than 5. So what I mean by that, when we're looking at the image on the right and the middle image, we take those diameters, we divide them, and that gives us our ratio. So this is highlighted on the slide. The largest diameter is 0.64, smallest diameter is 0.08, and that gives us a diameter ratio of 8. So this patient is considered positive purely off of their diameter ratio. So in this slide, we're actually looking at peak vein velocities. And I want to highlight here, anytime that we are looking at venous velocities, we need to use angle correct. We have to have a velocity angle. This is very important. A lot of people think about angles only being used for arterial exams. And the reason we use them for arterial exams is because we're focusing on velocities. We're doing the same thing here, so we should be using angle correct. So in this patient, I don't have the actual velocity ratio, but I wanted to highlight that patients will not always be positive by a diameter and velocity ratio. The criteria doesn't read that way. It's velocity or diameter ratio. As far as the common iliac veins are concerned, we don't have any set diameter criteria. Generally, when we're scanning these patients, we visibly see that these segments are narrowed by B mode. And then we are looking for a velocity elevation greater than 2.5 when compared to the peripheral venous segment. So we're looking at the image on the slide here, right where that arrow is pointing, we're seeing some scarring, we're seeing some narrowing there. So that would be your stenotic velocity. And to the right of that arrow, which would be your pre-stenotic velocity. You're going to compare those two velocities, and that's going to spit you out a ratio. This one was just an interesting case that I scanned a while back. The ultrasound image on the left, you can clearly see the right external iliac artery. And generally, you should be seeing the right external iliac vein just posterior to that artery. But I didn't see that in this case. I was getting little blips of flow through there, but you're getting a large collateral coming off the distal external iliac vein coursing deep into the pelvis. And that's a telltale sign that something proximally is obstructed. For us, the first step in our protocol is to look at the bilateral common femoral veins. And these are the waveforms that I obtained. So I already knew that I was going to come across something, or I expected to come across something in the abdomen on the right side of this patient. That patient went on to have venography, in which they were found to have an occluded right external iliac stent, and you can clearly see that large collateral vessel coursing around that stent. So for internal iliac veins, I put diameter greater than 5 millimeters question mark. I've heard this diameter thrown out quite a bit, but I don't know that there's enough research to suggest that if an internal iliac vein is greater than 5 millimeters, that it's always abnormal. So in our lab, at least, we don't use that criteria. What we're looking for is more so has to do with flow dynamics. So is this vessel refluxing with or without Valsalva, or augmentation? Is there retrograde flow? And generally, when we find retrograde flow, that's because of a proximal obstruction, which is not necessarily the case if that internal iliac vein is refluxing. Stop my videos here real quick. So these are some venography clips of a patient that we scanned. We saw retrograde flow within the internal iliac vessel, and this is what their venogram showed. This is pre-treatment. So you can clearly see there's not a ton of opacification in the left proximal common iliac vein. So a lot of that flow is hitting the wall, basically, or a tight narrowing, and flowing retrograde down that internal iliac vein on the left, across the pelvis, and up and over into that right internal iliac vein. And then this is a patient post-balloon angioplasty and stenting. Apologize, I always struggle with my videos. So this is post-treatment. You can clearly see that that proximal segment that wasn't filling before is now filling with contrast, and that patient is now good to go. So as far as gonadal veins, we rely heavily on diameter measurements. So again, just anterior to that psoas muscle on the right and the left, any diameter greater than 6 millimeters is a great predictor of gonadal vein disease, up to 99% positive predictive value based on some peer-reviewed literature. And there are some articles out there that suggest that diameters greater than 8 millimeters, you're going to see retrograde flow, generally speaking. So this is a patient that underwent venography for potential gonadal vein coiling. And this clip clearly shows you that the further distal we get, the closer to the ovary and the testes that we get, you're going to see multiple trucks often within the gonadal system. So just wanted to highlight that there because I get a lot of questions on that. A lot of people think that it's generally just one gonadal vein. So what are these other trunks that I'm seeing that can be a part of the gonadal vein system? And that's pretty common. So this is pre-gonadal vein coil. This one is dilated, appears pretty large. And then this is post-coil placement. Another thing I wanted to highlight here is that coils are not meant to fully occlude that vessel. They may not, but all the physicians are doing by coiling a gonadal vein are increasing the resistance within that vein, so that flow redirects to where it should be going. So flow is always going to go from a high pressure system to a low pressure system, and these coils create a high enough pressure in that gonadal vein to force that blood back into the left renal vein and into the vena cava where it should be. And this patient ended up having bilateral coils. So you can see left-sided coils here. And then this is during treatment. They're still injecting that contrast to see if those coils are doing their job. In terms of peri and transuterine veins, any diameter greater than 5 millimeters is what we use in our lab. Often from a transabdominal approach, you can see these vessels a bit easier from a transvaginal approach. But I like to use the Valsalva technique with color on. That'll clearly light up those veins for you because we want to make sure that you're going to see arteries and veins. We want to make sure that we're accurately measuring venous diameters and not arterial diameters. So I often use the Valsalva technique to light that uterus up so I can clearly see or differentiate between arteries and veins. I then put pulse wave on the structure that I think are veins to make sure that we get venous waveforms, and then I take my diameter. And then I'm not sure how many people scan the scrotum, but like I said before, males early on, when we were talking about pelvic congestion, were often left out. So this is an image of bilateral testicles, and then we're measuring some dilated veins or varicoceles that are measuring greater than 3 millimeters. So this patient would be positive and needs further workup. So it is important to know when you are scanning testicles, or if you're new to scanning testicles, we know that compression on the left of the iliac vein, the left renal vein, is a lot more common than on the right. So if you see a patient with an isolated varicocele isolated to the left scrotum, that's probably an okay finding. We're not going to be concerned about mass effect further up in the abdomen. If you see this bilaterally, same thing, pretty common. But if you are scanning a patient and you see varicocele isolated to that right scrotum, that patient needs further workup to rule out abdominal pelvic mass. So we need to get them further imaging to make sure that there is nothing else in that pelvis or abdomen causing isolated right-sided varicocele, because it is not as common as left-sided varicocele and bilateral varicocele. All right, so now we're gonna switch gears here and talk about SVP. So what is it? It's the symptoms, varices, and pathophysiology classification of pelvic venous disorders. And what does this allow us to do? First and foremost, it allows us to define this disorder. We all know more research on this topic is needed. In order to research something, you first need to define that something. Secondly, based on the patient's symptoms, varices, and pathophysiology, it allows us to group patients into like buckets. This allows for communication between physician disciplines when trying to decide how best to help these patients. So I'm not going to run through the entire SVP classification today. That could be a whole talk by itself. But we should all do our own research. We should take a look at this, and hopefully more and more physicians and vascular groups are starting to use this classification, so we are all starting to use the same language. So I saved this slide for later in the presentation. Generally, you talk about risk factors and then symptoms, but I think this slide alone clearly alludes to why the SVP classification came about and why it's so important. Symptoms for pelvic venous disorders can arise as high up as the flank in the patient's abdomen, all the way down to the patient's ankle and feet. Not many other disorders or diseases have this wide array of symptoms. Just by looking at the number of different symptoms in different areas of the body that may indicate pelvic venous disorders, you can see the urgency needed to define this disorder and be able to bucket these patients into categories. So pathophysiology in terms of bucketing these patients is also highly important. The same pathophys can lead to different symptoms in different patients, and this is due to uncompensated or compensated flow. So on the right, the diagram illustrates normal flow patterns within the iliocaval, renal, and gonadal systems. Blood flow in the lower extremities drains via the common and external iliac veins, which connect with the vena cava and eventually ends up back at the heart. Blood within the pelvis drains via the internal iliac and gonadal veins. And the internal iliac veins anastomose with the common and external iliac veins, while the left gonadal vein connects into the left renal vein, and the right gonadal vein routinely drains into the IVC. This diagram also highlights flow patterns. This is what we normally or would expect when we're scanning a normal patient. These little arrows are the blood flow. So this is a normal system, undiseased system. So in our first example, this patient has what we call uncompensated left renal vein lesion, meaning the left gonadal vein is still flowing in its normal direction, coursing or draining from the pelvis into the left renal vein. So due to the left renal vein lesion, some or most of that flow is going to back up into the renal hilum, creating renal hilar varices. And this patient is going to experience kidney symptoms, but may not experience pelvic symptoms. So our next example, different patient. This patient has the exact same left renal vein lesion as the previous patient, but this flow is compensated by the gonadal vein. Flow exits the renal hilum normally through the peripheral left renal vein. However, the pressure where the lesion is in the central portion of the left renal vein is higher than in the gonadal vein. The flow always goes from high to low pressure. That flow is going to wrap down that gonadal vein, creating pelvic varices. So this patient with the same lesion as the previous patient will likely not have any kidney symptoms. Their symptoms will likely be isolated to the abdomen and pelvis if they have them. This is our next patient and has a bit more complex disease. They have the compensated left renal vein lesion that our second patient did, but they also have a left common iliac vein lesion, which is being compensated by the left internal iliac vein. So flow is now routing through the pelvic varices, just like that venogram patient that we saw. This is via 2 channels. And this patient may have symptoms affecting more reservoirs than just the pelvis. So the last point I want to touch on in pathophysiology is reflux versus retrograde flow. These two are similar, but it's very important, in my opinion, to distinguish between flow that is retrograde and flow that is truly just reflux. So refluxing vessels will generally have antegrade flow at rest. Flow will then begin to flow backwards for a short time only after a provocative maneuver, such as augmentation or Valsalva, is performed. So this is usually due to the lack of valves within the vein or lack of functioning valves. Vessels that have true retrograde flow will be retrograde at rest without a provocative maneuver. This generally indicates a more proximal obstruction, creating high outflow resistance. The body is the best plumber I know. Blood will find its way to a lower pressure system in order to get back to the heart. And I'll tell you why I'm bringing this up. We had a patient come to one of our clinics in South Florida roughly about a year ago. And luckily we had a great provider in that office. He looked at all of the images. I know providers are busy and we're kind of getting away from looking at ultrasound images and just signing reports, but this physician was highly dedicated to his practice and his patients, and he looked at every study that came to him. So the sonographer did a good job with ultrasound documentation, didn't do such a great job with reporting. So this patient, which is this patient in the bottom right image, clearly had an outflow obstruction on the right. That flow in the right common femoral vein is retrograde. That is not reflux. He still performed an augment. And then in some of his images, luckily this was in there, some of the images were so short, the sweep speed wasn't long enough, that it did actually look like reflux in that common femoral vein. But then you could clearly see flow back flowing through the right common femoral vein up into the epigastric vein. So that epigastric vein was acting as a collateral channel, and then all the flow within the truncal veins in that lower extremity were retrograde as well, at least near the groin. So anterior accessory, posterior accessory, GSV, all the flow in those vessels was also retrograde. So that physician recognized that. It was reported as reflux, but in looking at the images, he quickly realized this is not reflux. This patient has a proximal obstruction. We need to get him a further workup. So they sent him to one of our office-based labs for a venogram, and that patient had a significant obstruction that we could not treat ourselves in an outpatient setting. So that patient was then referred to a hospital, and he got revascularized. And a lot of his patients actually resolved without us touching the superficial system. So that's why I think this is important to bring up. And when to intervene. I get this question a lot from our sonographers as well. Like, hey, Michael, I just scanned, full abdomen, pelvis, found a left renal vein lesion, but that patient's not going to get that treated. So this is not an easy question to answer. It's 100% physician and case dependent. And I want to leave you with this. Physicians treat the symptoms, not the diagnostic findings. So we just talked about compensated versus uncompensated flow. 2 patients with the same exact left renal vein lesion have widely different symptoms. So just because that patient or your patient has left renal vein lesion does not necessarily mean that segment needs treatment. I spent a lot of time talking to our physicians about this, and this is about as clear of an answer as I can give. And then the last part of this talk, I wanted to focus a bit on techs that work in vein clinics. Donna Kelly gave a great presentation a few years back at AVLS titled When to Look Up. The bread and butter of vein centers is superficial venous insufficiency exams, and most techs working in these centers are experts at direct examination of the axial and tributary veins that live in our legs. During her talk, she highlighted the importance of understanding source to course. Reflux has to come from somewhere and it has to go somewhere. A lot of patients can have straightforward disease patterns where the reflux originates and ends in the lower extremity. Well, what if that's not the case? We need to do right by our patients, be able to recognize when the source of their disease may be higher up. So as a vein clinic sonographer, how do we recognize this? There are 4 common leak points from the abdomen that suggest a patient may need further workup to evaluate their abdominal pelvic vasculature. There's the I or inguinal point, the P or perineal point. This is where patients get their vulvar and scrotal varicosities from, the O or obturator point, and the G or gluteal point. And the goal here is not to memorize all these points. We need to know that they exist, and we need to be readily be able to identify these when something's not quite right when we're scanning the lower extremity. These are just 2 examples of patients with abdominal pelvic disease as the source of their lower extremity symptoms. Take home here, again, turn the lights on in your rooms, visually inspect the patient's leg prior to scanning. Not only will you set yourself up for a successful exam, you'll be setting your patients up for successful outcomes. This patient on the left is a gluteal leak point. You can see this varicosity coursing up the posterior aspect of the left thigh, coursing right up into the buttocks. That's a telltale sign that this patient, although maybe she does have axial vein reflux and maybe on the anterior aspect of the leg, that is the source. On the posterior aspect of her leg, the abdomen and pelvis is definitely her source. Similarly, the patient on the right, which is the inguinal point, these varices are not originating in the leg. It's originating in the abdomen and pelvis. So we need to have these conversations with our physicians. But before we end, I'd like to leave you with some considerations. Phasic downstream flow does not entirely exclude a proximal obstruction. So what does that mean? If we're looking at the common femoral veins in the lower extremity and we see phasic flow, that does not necessarily mean that that patient does not have a proximal obstruction. The pelvis is a great collateralizer. I'm sure most of us have heard that a lot, and it is true. And sometimes flow is not going to be continuous or dampened when that patient has an obstruction. Always use Doppler angles when measuring venous velocities. This is not just an arterial requirement. Know when to look up. And finally, this is a very complex disorder. We're all still learning and more research is needed. Thank you.
Thanks, Michael, for that very detailed presentation. As you can imagine, we have a lot of questions here, so we're going to try and get through as many as we can. The first question, what causes this condition in male patients?
A lot of it is the same as in female patients. So if we're talking about the left side of the vasculature, left renal vein compression, left common iliac vein compression, males and females generally, in terms of vasculature, have the same anatomy.
Great. This question says, it's often been said that if a patient has a large round abdomen and is gassy, it helps to image the abdomen and pelvic vessels with the patient's legs sitting up. Do you have any thoughts on patient positioning for that?
Yep, I've used that technique. Not a lot, but in those patients where imagine they're lying supine, their abdominal muscles are going to be pretty tight, right? So just by elevating those knees a little bit, it's going to lessen the tension on their abdominal muscles is going to allow you to push a little bit more. So that's different than somebody that's generally barrel chested and has that big, firm abdomen. You can try that technique, but I'm not quite sure that's going to help much for a patient with a big barrel chest and a tense, round abdomen.
Gotcha. We have questions about criteria and protocols. Where would people find good references for protocols and criteria for evaluating the pelvic veins?
So SVU, and I forget the name of their page, has a lot of sample protocols. That's where I go often, and it's a wide variety of vascular protocols. It's not just pelvic venous disorders. They have arterial, lower extremity venous, upper extremity venous. So I would head to the SVU website and look for those. In terms of diagnostic criteria, I generally read quite a bit of peer-reviewed literature, and also bounce a lot of questions off, like Donna Kelly and things like that. She's very open to us reaching out to her and asking, where she found her criteria and things like that. So when I was pretty early on, Bonnie Brown, who's president of Pacific Vascular, she kind of taught us a lot of this diagnostic criteria, which still rings true today, at least in the peer-reviewed literature.
Great. We have a question about angles. How do you determine if your angle correct is set properly while using the curved probe? What guidelines do you use?
So I strive for 60 degrees always. So that way we're comparing apples to apples. So if you're consistently 60 degrees and using the heel toe approach to optimize that angle within the vessel, so you're not actually changing the angle, like the fine angle steer, that angle is still at 60 degrees. And then I use my hand to kind of do that with a pulse wave Doppler slide towards the feet or towards the head, depending on vessel course, and then line that Doppler up within the vessel. Again, not super easy when you're new to that. I struggled with it for a long time, but once that light bulb clicks or turns on, it's so much easier to scan the abdomen. You don't waste a lot of time. Your hand quickly does. It basically angle corrects for you without you even thinking about it after a while.
Great. So just a lot of practice.
Yeah.
We had a couple of questions when you were showing the slides for the peri and transuterine veins. One question was, what's the follow-up time for a patient like that? I'm assuming after a procedure's done. I think that's what they're referring to.
So that is patient and so it's patient dependent, and it also depends on what they treated. We generally don't follow up on coils, at least in our lab. They do have an office visit with the physician at certain periods of time. And that is definitely physician dependent, because we have 3 or 4 physicians in 4 different states doing these exams, and their patients come back at different times depending on which patients or which physicians they're seeing. In terms of stenting, generally we bring that patient back to the office to meet with the physician a week after they had the procedure, and then a month after that they come back for a follow-up ultrasound exam. But we don't look at the gonadal vein coils.
Gotcha. So that patient in particular, do you have any idea what the age of that patient was?
I don't, off the top.
Okay, I kind of figured, but I thought I would ask. Let's see. Do you get infertility patients for imaging referral?
Off the top of my head, I do not know that, but I would assume yes.
We have a question. It says, you mentioned Valsalva when imaging the iliac veins, pelvic veins, gonadal veins. Regardless of patient's body habitus, when one performs a Valsalva, the vascular anatomy moves.
Mhm.
Would you suggest a proximal IVC compression performed by the sonographer rather than the Valsalva?
Yeah. So we have a pretty limited tool bag, right? When we're trying to elicit reflux in the abdomen. So there's proximal augmentation. You can use a distal augmentation based on what you're looking at. Generally, it's kind of hard to squeeze the proximal thigh hard enough and adequately enough to elicit reflux in the iliac system. But that is a technique. And then Valsalva is probably the third thing that I try because everything moves. And I've learned over the years, mainly in scanning lower extremity venous exams, you really got to get good at describing what you want your patient to do before they do the Valsalva. So if you're not good at explaining what a Valsalva is, your patient is not gonna do what you want them to do. So generally, I have them start with a deep breath in. I take a look at what's moving and how it's moving, and then I try to mimic that movement. And because some people are harder than others, right? It's not going to work on everybody. So some people, when they take a big deep breath in, everything just moves too much. You're not going to be able to see anything. So it's patient dependent, but I hone in, at least when I'm training my sonographers, I hone in on the conversation that they have with the patient when they're asking them to do the Valsalva maneuver. You can also scan your patient upright. Also somewhat challenging depending on the patient, but those are probably the only four techniques that we have.
Kind of piggybacking off of that, there's a question about the gonadal vein as well as the ovarian and varicocele sides. Are they taking resting or with Valsalva?
I take mine resting.
Um, for female patients, do you do any vein imaging outside of the uterus?
Mm, Other than, so our protocol is full iliocable workup. So basically from common femoral all the way through the external common iliac, internal, if you can see it, vena cava, left renal vein, bilateral gonadal veins, and then the uterine veins as well. We don't include the lower extremities, but we pretty much cover the entire abdomen, pelvis in terms of vasculature.
Okay. Do you feel that transabdominal imaging is sufficient to diagnose, or should intravaginal imaging be considered at all times?
I think it is in most patients, given they don't have extensive amounts of bowel gas. Because if the ovarian vein is abnormal, I'd say in the majority of patients, you can isolate the psoas. If the ovarian vein is abnormal, you're going to be able to see it. If you can't see it, generally it's because it's, as long as you're seeing that psoas clearly, if you can't see the ovarian vein or the gonadal vein, it's generally because it's pretty small. And in speaking to our physicians, a gonadal vein size greater than 6, if that's all you can get, that's enough, based on symptoms and things like that, to at least get them a further workup, like a venogram. Not everybody is amenable or going to get the same results from ultrasound. We have other imaging modalities, and some patients need that in order to get a correct diagnosis.
Okay, roughly how much time do you dedicate to a pelvic venous exam?
Generally, these are set for 90 minutes. They don't always take 90 minutes. Some actually take a little bit longer. But I'd say the majority is right around or less than 90 minutes.
When you talked about diameter measurements, should you take them outer to outer, inner to inner, or right on the borders?
So proper way to do that, outer to outer, is what we are taught, right? But the walls can sometimes be difficult to see. So I have my sonographers sandwich them right on the wall. And as we are using IBIS more and more, where IBIS is within the lumen of the vessel, they're not seeing the wall. I think that is getting us closer to an apples to apples comparison in terms of ultrasound to intravascular ultrasound. And we're still not doing it the improper way of measuring inner to inner. If that answers your question.
And do you routinely take those measurements in sagittal or in transverse?
It depends on the patient, honestly. I have more success, at least in gonadal veins, imaging them in sagittal. But in terms of iliac veins, if you're in the distal external iliac, for example, that's crossing over the bone before it dives deep into the pelvis, I get better visualization of that vessel in transverse with the machines that we use. So whichever view allows you to clearly delineate those vessel walls better, I would use that.
Okay. This listener, they've seen that 2 millimeters is the normal diameter for a testicular vein. So just wanted to clarify, I think on your slides, you said 3 millimeters is the criteria that you've been using.
So again, there's going to be varying diagnostic criteria out there. That's just what our lab uses. And way back when I worked at Kaiser Permanente in Denver, that's what we used there. So there's going to be some variance between labs.
Let's see. This is an interesting question. Would you ever try to coordinate a female patient's pelvic congestion ultrasound exam with her menstrual cycle when she's more symptomatic? Do you encourage a dynamic exam to further provoke or prove the congestion?
I've never thought about that, actually. That one I do not have an answer for.
Okay. We'll go back to diameters. They have a question about patient positioning and the effect on diameters. Have you found a significant difference in diameters when the patient is put in a supine to oblique position, or any positional changes that affect the diameter measurements?
Yeah, there is some difference, and you'll see this. Like the easiest way to assess this is lower extremity venous patients. So if you lay somebody down, their vein becomes more of like an oval.
Okay.
And then when you stand them up for 5 to 10 minutes, and those venous reservoirs, vessels are able to fill higher pressure within that system, they are going to dilate. And that rings true for all venous reservoirs.
Okay. Looks like we're moving into symptoms now. What are the most common symptoms for gonadal venous insufficiency?
They are so widespread. I think it depends on where you work, honestly. In our vein clinics, we're probably not going to get as many people with pelvic heaviness and, renal symptoms and things like that. We do see occasionally vulvar varicosities. We see some of those pelvic leak points. But generally in those clinics, their main symptoms, or at least the symptoms that they're talking to us about, isolated to the leg, like edema, varicosities, things like that. If you work in an OBL or an office-based lab where you're seeing all kinds of different patients, it gets a little bit more complex. So I would say pelvic fullness, postcoital pain are probably two of the most common that I see.
This is interesting. Are symptoms for right-sided varicocele the same symptoms as the left side?
Generally speaking, from my experience, yes.
This listener is asking, are these typically done in a vascular lab or radiology? They've never seen them in their vascular lab. They haven't been ordered there. Is this typical?
Yes. So it depends. Our labs are set up with a physician that also treats, right? So it's whatever that physician is comfortable with. And it also depends on their scope. So I primarily work with interventional radiologists who have a lot of experience in treating gonadal vein insufficiency. So it does depend on your lab for a number of different reasons, but that's probably the biggest one that I've seen.
Now, do all your techs do this exam, or is it a specialized group of techs that are assigned to do the pelvic exams?
So I will say, when I was in Seattle, there was a select few of us that did them. But in a smaller lab where you only have 3 techs, it's probably wise, and why we did this in some of our locations, we trained everybody. The issue with that is you have to have a significant volume to become comfortable with this exam. So the more bodies you have doing them, if your volume is not high enough to stay, up to speed with the exam, it's going to get even harder if you got multiple people doing it. So it's not a bad thing to have an expert in the clinic, but what if that expert's out sick or wins the lotto and quits tomorrow? So like to have some redundancy.
Gotcha. I have a couple of quick questions about protocols, and then I think we might have to wrap it up. First question, when there's collaterals present, do you image and interrogate the collaterals or just document that you saw them?
So I generally just document that I saw them, like in that external iliac vein image, clear as day, that's collateral vessel, and that's not going to be the external iliac vessel. Something that I maybe didn't highlight as well as I should have is gonadal veins, internal iliac veins, in terms of left renal vein lesions and common iliac vein lesions are the collaterals. So we are documenting them as part of the protocol. But unnamed vessels that are collateral channels that you may see, I generally just take some images with color just to show, their course in relation to where that vessel should be. And that's generally enough for our physicians to paint them a clear picture.
When your lab evaluates for pelvic disorders, do you routinely evaluate for nutcracker?
Yeah.
Yeah. Okay. And then last but not least, if you won the lottery, would you leave your facility, Michael?
The lottery? Probably not. I think I would get bored. I might leave, take a sabbatical for a couple months and travel with family, but then.
So we can still count on you.
Yes.
Okay, great.
Great answer, Michael. Thanks again, everyone. And then a very special thank you to Michael Grant for this presentation today. Please feel free to contact IAC with any questions that were not answered during the Q&A session. To receive continuing education credit for attending this webinar, please complete the survey. The link to the survey will appear on your screen automatically at the conclusion of the live session and also be available from the IAC webinar portal for 3 business days. On the left side of my account page, you'll click on webinars. Look for the title of this session, Pelvic Venous Disorders, Gonadal Vein Insufficiency. Beneath this title, you will click Review Event. Then click Take Evaluation to complete the survey. Your certificate can then be accessed and printed from the very next screen at any time thereafter through the CE transcript section on the My Account page. Please note that this certificate will not be emailed to you. If you have any questions about the survey, please contact us at webinars@intersocietal.org. Once again, we thank you for joining us today and appreciate your participation.